Understanding Thrombocytopenia, a clinical deep dive. Welcome to our podcast, where today we embark on a comprehensive exploration of thrombocytopenia. This condition, defined by a lower than normal number of platelets in the blood, has significant implications for health, particularly in relation to bleeding and clotting. Introduction to platelets and thrombocytopenia. Platelets are tiny, disc-shaped fragments circulating in our bloodstream. Their primary role is to act as the body's first responders whenever there is an injury, helping form blood clots that prevent excessive bleeding. The standard range for platelet counts in healthy individuals falls between 150,000 and 450,000 platelets per microliter of blood. When the count drops below this range, we refer to the condition as thrombocytopenia. The severity of thrombocytopenia varies. A mild reduction may go unnoticed, while moderate levels can cause easy bruising. Severe drops in platelet count, especially below 50,000 platelets per microliter, significantly increase the risk of bleeding. When counts fall under 20,000, spontaneous bleeding may occur, and urgent medical attention is required. Causes. Why does thrombocytopenia occur? To grasp thrombocytopenia, it is essential to understand the mechanisms that lead to low platelet counts. There are three chief pathways: reduced production, increased destruction or consumption, and sequestration. Reduced production in the bone marrow. First, the bone marrow may fail to produce enough platelets. This can be the result of cancers such as leukemia or lymphoma, which affect bone marrow function. Aplastic anemia is another culprit, wherein the marrow's ability to manufacture blood cells is compromised. Deficiencies in vital nutrients like vitamin B12 or folate can also play a role. Certain viral infections, human immunodeficiency virus, hepatitis C, Epstein-Barr virus, or parvovirus B19, are known to suppress bone marrow activity. Exposure to toxins, including excessive alcohol or chemotherapy drugs, as well as radiation therapy, can further reduce platelet production. Rare genetic conditions, such as Wiskott-Aldrich syndrome, may also be involved. Increased destruction or consumption. The second pathway involves platelets being destroyed or used up faster than they are produced. Immune thrombocytopenia is an autoimmune disorder where antibodies target and eliminate platelets. Some medications, like heparin, certain antibiotics, or quinine, may provoke an immune reaction that destroys platelets. Heparin-induced thrombocytopenia stands out as a particularly serious condition, where the drug paradoxically causes both clotting and low platelet counts. Thrombotic microangiopathies, including thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, are conditions in which widespread tiny blood clots form and consume platelets. Disseminated intravascular coagulation is another severe complication of illnesses such as sepsis or trauma, leading to extensive activation of the clotting cascade and simultaneous consumption of platelets and clotting factors. Mechanical destruction may also occur, for example, when artificial heart valves or abnormalities in large blood vessels shear platelets as blood passes through. Sequestration. Platelets trapped in the spleen. Finally, platelets may become trapped in an enlarged spleen, a condition known as splenomegaly. This pooling reduces the number of platelets circulating in the blood. Causes include cirrhosis of the liver with portal hypertension, congestive heart failure, and certain cancers such as lymphomas. Recognizing the signs and symptoms. Symptoms of thrombocytopenia often mirror the degree of platelet reduction. One of the most recognizable signs is petechiae, tiny red or purple spots on the skin, usually appearing on the lower legs. Purpura are larger bruises resulting from bleeding beneath the skin, and ecchymosis refers to easy or excessive bruising from minor trauma. Prolonged bleeding, whether from small cuts or dental procedures, may be observed. Some individuals experience bleeding from mucous membranes, including frequent nosebleeds, bleeding gums, blood in the urine, or blood in the stool. Women may notice heavy menstrual bleeding. Fatigue can also occur, particularly if anemia is present. In the most severe cases, thrombocytopenia may result in life-threatening internal bleeding or even bleeding into the brain. Diagnosis. How is thrombocytopenia identified? Diagnosing thrombocytopenia begins with a thorough medical history and physical examination, investigating bleeding tendencies, recent illnesses, medications, alcohol use, and family history. Physicians examine for bruising, petechiae, and an enlarged spleen. A complete blood count confirms the platelet count and assesses other blood cell types. Examination of a peripheral blood smear provides insight into platelet size, shape, and clumping. while also revealing any abnormal cells. Further testing may be conducted to uncover the underlying cause, including bone marrow aspiration or biopsy, particularly if a bone marrow disorder is suspected. Imaging, such as ultrasound, to detect enlarged spleen or liver. Tests for autoimmune antibodies, to diagnose immune thrombocytopenia. Screening for infections or nutritional deficiencies. Specialized tests for disseminated intravascular coagulation or thrombotic thrombocytopenic purpura, such as D-dimer, fibrinogen, and lactate dehydrogenase levels. Treatment and management. Management of thrombocytopenia depends entirely on its cause and severity. The primary objective is to address the underlying problem. For drug-induced cases, discontinuing the offending medication is critical. Treating infections, cancers, or autoimmune conditions is equally important. Supportive care may include platelet transfusions, reserved for patients with active bleeding or very low platelet counts at high risk for spontaneous bleeding. However, transfusions are not appropriate for all causes. For example, they are typically avoided in thrombotic thrombocytopenic purpura and heparin-induced thrombocytopenia. For immune thrombocytopenia, treatments include corticosteroids, intravenous immunoglobulin, anti-D-immunoglobulin, thrombopoietin receptor agonists, and in refractory cases, surgical removal of the spleen. Heparin-induced thrombocytopenia requires immediate cessation of all heparin and substitution with another anticoagulant. In cases of thrombotic thrombocytopenic purpura, plasma exchange therapy is essential. Lifestyle adjustments and precautions are also recommended. Patients should avoid activities that carry a high risk of injury or bleeding, such as contact sports. Medications that increase bleeding risk, like aspirin, ibuprofen, and similar agents, should be avoided. Limiting or abstaining from alcohol is advised. Summary and closing thoughts. Thrombocytopenia is not a disease in itself, but rather a symptom pointing to an underlying issue. It can range from an incidental finding with no consequences to a critical emergency requiring swift intervention. A systematic approach, focusing on the mechanisms of decreased production, increased destruction, or sequestration, remains the key to identifying the cause and guiding appropriate treatment. With careful diagnosis and tailored management, thrombocytopenia can be effectively addressed, ensuring the best possible outcomes for patients. Thank you for joining us in this deep dive. We hope you found our discussion enlightening. Stay tuned for more episodes exploring the fascinating world of medicine. It's the Everything Surgery Podcast. Dissect the extraordinary.